Proposed TNM-9 classification for salivary gland carcinoma. Welcome back to the Head and Neck Oncology Journal Club. Today we are covering a paper that will directly affect how we stage every salivary gland cancer going forward. The paper is from Xiao Hui Huang, Ian Ganley and colleagues from multiple international institutions, mainly from USA, published in JAMA Otolaryngology Head and Neck Surgery on February 12, 2026. It proposes a new TNM classification for salivary gland carcinoma for the upcoming AJCC 9th edition. Remember, this is just a proposal. And here is the problem. The current TNM-9 classification was designed for mucosal head and neck squamous cell carcinoma and not for salivary gland tumors. Here, in a data set of over 7,600 patients with M0 salivary gland cancer from National Cancer Database, the N2A, N2C, and N3 categories each contained fewer than 50 patients, less than 1% of the cohort. Survival differences among N2A, N2B, and N2C were minimal. The system simply does not discriminate meaningfully in salivary gland carcinomas. On top of that, minor salivary gland cancers are currently staged using site-specific mucosal head and neck criteria, despite sharing similar prognostic factors with major salivary gland tumors. A disease-specific classification was overdue. The study. The authors used NCDB or the database to derive a new PTNM classification from 8,409 surgically treated major salivary gland cancer patients, including 7,659 with M0 disease. The median age was 60 years. The median follow-up was 88.4 months. Then they validated it in two independent cohorts, 1,015 major salivary gland cancer patients from 4 international centers in Canada and Brazil, and 444 minor salivary gland patients from Memorial Sloan Kettering. They evaluated two key prognostic features: the number of pathological positive lymph nodes and extranodal extension status. What did they find? Among the patients without extranodal extension, survival was similar whether you had 1, 2, or 3 positive nodes. The 5-year overall survival ranged from 60 to 68%, but more than 3 positive nodes dropped the overall survival to 47.5%. Extranodal extension positive patients had the 5-year overall survival of 41.4%, regardless of whether ENE was minor or major. Both features were confirmed as independent prognostic factors on multivariable analysis. The proposed N classification, PN0, where there are no positive nodes, PN1 with 1 to 3 positive nodes without extranodal extension, PN2 more than 3 positive nodes or any extranodal extension positive nodes. 3 clear categories instead of 6 with distinct survival separation like 87, 66, 43% at 5 years. The proposed stage grouping. Stage 1 is T1N0, Stage 2 is T2N0, Stage 3A is T1 to 2 and N1 or T3 to 4 with N0. And Stage 3B is T1 to 2 N2 or T3 to 4 N1 to N2. Stage 4 is M1 disease only. This is a significant conceptual shift. All the M0 cases are confined to stage 1 through 3, and stage 4 is reserved exclusively for metastatic disease. This approach mirrors the staging philosophy already adopted for HPV positive oropharyngeal cancer and nasopharyngeal carcinoma. The T classification remains largely unchanged because it already works well. However, the definitions were revised to apply to both major and minor salivary gland cancers. Gross extraparenchymal extension, or as a T3 criterion, applies only in major salivary gland cancers. Minor salivary gland cancer is classified by the size alone for T1 through T3. Now about the validation. The International Major Salivary Gland Cancer Cohort showed clear stage separation. The 5-year overall survival was 95%, 92%, 80%, and 41% across stages 1 through 3B. The minor salivary gland cohort from MSKCC showed the same pattern. The system worked in both WHO low aggression and high aggression subgroups. The proposal went through a Delphi process with 14 international experts and achieved 100% consensus. Limitations. The NCDB does not record lymph node level or parotid versus cervical location. So, potential prognostic differences between these types could not be assessed. Overall survival was the endpoint and not the disease-specific survival. The minor salivary gland cancer validation cohort is relatively small, and the system is based on pathological staging from the neck dissection specimen. So, clinically, TNM applicability remains to be validated. And here is the bottom line. The proposed TNM-9 introduced the first salivary gland carcinoma specific staging system that unifies major and minor salivary gland cancers and under one framework. The new PN replaces 6 poorly separating categories with 3 based on positive node count and extranodal extension status. Stage 4 is reserved for M1 disease. It is simpler, better calibrated, and validated across multiple international cohorts. For surgeons and pathologists, start reporting positive lymph node counts and ENE status systematically. This will be the key nodal prognostic factors in the TNM-9 mostly. And that's your podcast summary. The full citation and the links are available in the show notes. Until next week, this has been Head and Neck Oncology Journal Club. Thank you.